Hi everybody, this is the pre-class PowerPoint on Neuro Part 1. Now the nervous system is the last of the body systems that we're going to be studying this quarter. And maybe in some ways it seems like it should have been the first system because it's so involved in regulating the function of the other systems. But one advantage that you probably have now that we're doing it at the end is that you now have the knowledge to better visualize how the nervous system acts to integrate or regulate the function of all the other systems. So maybe the big picture of what the nervous system does will be easier for you to get. So on that note, let's start with an overview of the nervous system. Okay, so we said the nervous system is involved in regulating the function of all the other body systems. Basically, if you wanted to put what the nervous system does into a really tiny nutshell, you could say that it does three things. It receives sensory information from different parts of the body, processes that information, and then transmits out the appropriate motor responses back out on the motor pathways to the rest of the body. Okay, so in this slide, if you look at the yellow arrows, okay, that's showing the sensory impulses traveling from the body to the brain. The brain is going to process it and then send out the motor responses indicated by the red arrows back out to the rest of the body. Now we usually divide the nervous system up into different divisions just so we don't get ourselves all mixed up trying to think of everything that the nervous system does all at one time. Okay, but keep in mind that these divisions are not distinct. They're not exact. There is a lot of overlap between the functions of the different divisions. So just don't get too rigid when you start thinking about that. Okay, so the two primary divisions are the central nervous system and the peripheral nervous system. And the central nervous system we divide into the brain and the spinal cord. And the brain is the part of the nervous system that does the processing of the information, taking in the sensory input, deciding what the appropriate responses should be, and then it transmits those out over the motor system. So the brain is the part that processes the information. This is the part that does your thinking, your learning. This is where your memories are, where your emotions are generated from, and so forth. The peripheral nervous system is more involved in the transmission of nerve impulses back and forth between the central nervous system and the rest of the body. Okay, so it's sort of the input-output system, bringing in the sensory information and then transmitting the motor responses back out. Now, we divide the peripheral nervous system into the somatic nervous system versus the autonomic nervous system. The somatic nervous system regulates the voluntary activities of your body, the things that are carried out by your skeletal muscles, whereas the autonomic nervous system regulates the involuntary activities of your body, the things that are carried out by your internal organs and your blood vessels, the things that happen without you having to voluntarily initiate them. Now we divide the somatic nervous system into the afferent or sensory pathways and the efferent or motor pathways. And we divide the autonomic nervous system into the sympathetic versus the parasympathetic divisions. Now, we've actually learned quite a bit about how the sensory, motor, and autonomic aspects of neural function work. What we don't know a lot about is the physiology behind the thought processes. How do people learn? How do we regulate emotions and those kinds of things? So what we're going to do today is focus on what we do know about the nervous system. For example, we know that the functional cell of the nervous system is called the neuron, and you see a picture of it here. And we know that neurons communicate with each other and with body cells at synapses, which are places where the two cells kind of meet. Okay, and they communicate with these other cells through action potentials. So at either end of the neuron, you see places where this nerve cell can synapse with a whole bunch of other nerve cells. And the synapses usually are one of two different types. So we have the electrical synapse there on the right. And you remember in the electrical synapse, we have a little ion that carries the electrical current that's going to pass directly from one cell to the next through the little gap junctions that you see in between the cells. And when the current-carrying ion passes from the first cell to the second cell, that's how the action potential passes very quickly from one cell to the next one. The second kind of synapse is the chemical synapse that you see pictured on the left. And what happens in the chemical synapse is when an action potential occurs in the first cell, that triggers the release of a chemical messenger, which in the case of the nervous system we call a neurotransmitter. So the neurotransmitter gets released from the first cell and binds to a receptor site on the second cell. And when that neurotransmitter binds to the receptor site on the second cell, that will either facilitate or inhibit the passing of the action potential to that second cell. Now, obviously, the chemical synapse works more slowly than the electrical synapse, right? Because in the electrical synapse, you just have to have the ion pass through the gap junction, whereas in the chemical synapse, you have to release a chemical messenger, have it bind to a receptor site, and that whole kind of thing. So the chemical synapse is a little bit slower, but still, it happens really quick. All right. As far as the neurotransmitters that work in the chemical synapse, there are a whole bunch of different neurotransmitters that are active in the nervous system. And I've listed some of them for you right there. I don't expect you to memorize them all, except for ones that I will specifically mention during class. Okay? But the reason why I'm not asking you to memorize all of these neurotransmitters and whether they're excitatory or whether they're inhibitory is because basically the activity of each neurotransmitter is determined by the kind of receptor site that it binds to. A lot of these neurotransmitters are excitatory at certain kinds of receptor sites and inhibitory at others. So it really is not useful to try and memorize all of these things. Just a brief review of some of the common problems that can occur at the different kinds of synapses. At the electrical synapse, remember if you have problems like electrolyte or acid-base imbalances, that can change how easy it is for the action potentials to pass from one cell to the next cell. Remember at the electrical synapse, you have to have active transport, right? You got to have the sodium-potassium pump or you can't repolarize your cells. If there are changes in membrane permeability, all of those kinds of things can affect how hard or how easy it is to generate an action potential at an electrical synapse. At the chemical synapse, remember you can have problems with things like releasing too much chemical messenger, not releasing enough chemical messenger. There could be a problem with the receptor sites. Maybe the receptor sites are missing or maybe they're damaged. Those are the kinds of problems that you might see at the different kinds of synapses in the nervous system. Now, in addition to the neurons, we also have what we call supporting cells in the nervous system. And I have listed some of the common ones for you in your study guide, and you see pictures of some of them on this slide as well. Now, I'm not going to ask you to memorize what these cells are called and so forth. What I'm more interested in you remembering is what the jobs of these supporting cells are. Basically, the supporting cells have three main kinds of functions. There are other ones, of course, but there are three primary functions. The first one is to provide protection for the neurons. Okay, in the central nervous system, there are a lot of supporting cells that contribute to what we call the blood-brain barrier. And the purpose of the blood-brain barrier is to try to protect the brain cells from any potentially harmful substances that might be in the blood vessels that are supplying blood to the brain. So in this picture, you see the blood vessel that's bringing blood to the brain in the middle, and surrounding the outside of that blood vessel, you see the ends of several different supporting cells that are kind of like providing a little covering around the blood vessel to try and prevent any harmful substances that might be in the blood from leaking out of the blood vessel and coming into contact with the brain cells. Now, this is a picture of the same kind of thing, but you might be able to get a better idea of how the ends of the supporting cells kind of provide a covering around the outside of the blood vessel. And in this picture, you also see that there are endothelial cells inside the blood vessel that are also trying to prevent harmful substances from leaking out of that vessel and coming into contact with the brain cells. So the endothelial cells are another part of the blood-brain barrier, in addition to the supporting cells that are around the outside. And the purpose of the endothelial cells and the supporting cells is, of course, again, to prevent harmful substances from leaking out of the blood vessel and coming into contact with the brain cells. Now, if something should impair the blood-brain barrier, there was a defect in the blood-brain barrier, the potential consequences might be damage to the brain cells, or maybe swelling of the brain cells, or you might even see substances coming in contact with brain cells that is going to abnormally stimulate it. So you might see things like seizures and that kind of thing. Now, there are supporting cells that serve a similar function in the peripheral nervous system, surrounding blood vessels to prevent harmful substances from leaking out of the blood vessels and coming in contact with the peripheral nerves. But of course, we don't call that the blood-brain barrier because it's not protecting brain cells, it's protecting peripheral nerves. Another job, the second job of the supporting cells, is to provide some metabolic support for the neurons. Remember we said most nerve cells really can't store a lot of glucose. There might be a little glucose in there, but they can't store glycogen. So the supply of fuel is very limited. So the neurons have to rely on the supporting cells to kind of make sure that there's fuel for the neurons to function. Okay, so that gray cell in the middle is the supporting cell, and it can store glycogen. And so if the amount of glucose in the blood drops, that supporting cell will break down its glycogen, release glucose into the blood, and provide a source of fuel for the neuron when it runs out of fuel. The third job of the supporting cells is to form the myelin sheath that surrounds the axons of a lot of nerves. And do you remember what the purpose of myelin is? Okay, the myelin is there to increase the speed of nerve conduction. Okay, so you see the little yellow myelin segments on the axon of this nerve cell. Okay, those myelin segments are supporting cells that have sort of wrapped themselves around the axon several times. And you notice that there are little gaps in between the myelin segments. We call them nodes of Ranvier. Okay, and the way that the myelin segments can speed nerve conduction is that the electrical impulse, instead of having to travel all the way down the entire length of that axon, that impulse can skip from node to node through the extracellular fluid and travel much quicker in that way than it can if it had to travel all the way down the length of the axon. We call that saltatory conduction, and that's how we speed up conduction. Now you can see in this picture that a lot of supporting cells actually can wrap around more than one neuron. And so the cell in this picture, the blue one, is actually providing myelin for at least 2 different neurons. Now, what do you suppose happens if the myelin gets damaged? Because, you know, we do have what we call demyelinating diseases, right? Diseases like multiple sclerosis, where the myelin in the central nervous system gets damaged, or Guillain-Barré, where myelin in the peripheral nervous system gets damaged. Those diseases involve damage to the myelin sheath. And what you see happening in this particular picture, this is an autoimmune disease, right? Because you see the little autoantibodies there, and those autoantibodies are attacking and destroying the myelin. Now, if you destroy your myelin, what problem do you expect to see? Okay, it's going to slow down or block nerve conduction. So what you're going to see are problems related to certain nerve signals, maybe being very slow or never getting to where they're supposed to be. Okay, let's switch gears for a little bit and look at the different divisions of the nervous system in a little bit more detail. Let's start with the central nervous system. You remember the central nervous system is divided into two parts. We have the brain and the spinal cord. And I want to look at the brain first. Okay, now there's several different ways that you can subdivide the brain. I don't happen to particularly like the way your book divides it up, so I'm dividing it up a little bit differently. I think this is probably the way that you looked at it when you studied A&P. Okay, so we're dividing the brain into four main parts. Okay, we have the cerebrum, the diencephalon, the brainstem, and the cerebellum. Let's talk about the cerebrum first. Now, we subdivide the cerebrum in a couple different ways as well. We can look at it as the left hemisphere versus the right hemisphere, or we can look at it as the cerebral cortex on the surface of the cerebrum versus structures that are located deeper inside the cerebrum, like your limbic system or your basal ganglia. I actually want to look at it that way. I want to look at the cortex on the outside versus the things that are deeper inside the cerebrum. So let's look at the cortex first. The cerebral cortex, as we already said, is the outermost layer of the cerebrum. It's the tissue that's like on the surface of the cerebrum. And we divide the cortex into different lobes. And each of the four lobes of the cortex has specific functions. Let's look at the frontal lobe first. And you see the red arrow in this slide is pointing at the frontal lobe. Now, the frontal lobe does a lot of things. One of the major things it does is this is the part of your brain that's involved in your thought processes. Okay, your motivation, your logic, your judgment, all of that kind of thing happens in the frontal lobe. Now, the frontal lobe also contains the motor cortex. So you see that green strip at the back of the frontal lobe. That's called the motor cortex. And this is the part of the brain that helps to coordinate voluntary movements in various parts of your body. Now, there is one particular part of the frontal lobe that I want to point out to you. We call it Broca's area, and you see it as kind of like a reddish, purplish, round area with the label Broca's area. Okay, now Broca's area is interesting because it's involved with the motor aspects of speech. And by that I mean it's involved in helping you actually be able to carry out the activity of speaking. Okay, if you have damage to Broca's area, you're going to develop what we call aphasia. And aphasia is the word that we use to refer to problems with language. Okay, but remember we said Broca's area is associated with the motor aspects of speech. So if you have damage to Broca's area, you develop what we call expressive aphasia. Okay, expressive aphasia means that you can understand what people are saying to you and you know what you want to say back, but you just can't put your thoughts into words. Okay, so you're having trouble with the motor aspects of speech. All right, now we have the red arrow pointing at the temporal lobe of the cerebral cortex. The temporal lobe is sort of located around the area of your ear, okay, which makes it handy for you to remember that the temporal lobe contains the auditory and vestibular centers. These are the parts of your brain that are involved in hearing and balance. Okay, now the temporal lobe also contains additional parts of the language center. As a matter of fact, the temporal lobe in one of your hemispheres is usually the dominant one for language. And in most people, it's the left temporal lobe that is dominant for language. So if you have damage to your left temporal lobe, you are much more likely to have aphasia problems, to have problems with your language abilities. Now, there is another area that I want to point out to you in the temporal lobe. We call it Wernicke's area. So you see it's that same reddish purplish color, only shaped more triangular now. There is another speech center located in Wernicke's area. And if you have damage to Wernicke's area, you develop what we call receptive aphasia, meaning now it's like you can't understand what people are saying to you. For the person with receptive aphasia, it's like all of a sudden everybody in the world is speaking a foreign language and you can't figure out what they're saying. Okay, usually it even affects being able to recognize written words as well. Now, it is possible for somebody to have both expressive and receptive aphasia. If that should occur, we call it global aphasia. So now this person has trouble understanding speech as well as actually carrying out the motor aspects of speech. All right, now we have the red arrow pointing at the occipital lobe there in the back. The occipital lobe contains the visual cortex. So this is where a lot of the input that comes in from your eyes gets interpreted. And then now we have the red arrow pointing at your parietal lobe. The most significant thing to remember about the parietal lobe is it contains your somatosensory cortex. So that orange strip that's next to the motor strip, that's your somatosensory cortex. And this is where a lot of the tactile sensory information gets interpreted. So we know what things feel like and what's causing them, where they're coming from, and that kind of stuff. All right, that's the cerebral cortex, the tissue that's kind of on the surface of the cerebrum. Now I want to look at a few of the structures that are deeper inside the cerebrum. For example, the limbic system is there located deeper inside the cerebrum. And you see in this picture some of the different parts of the limbic system. I don't expect you to remember all of these names. This slide is just for you to be able to visualize how the limbic system is located a little bit deeper inside the cerebrum. Now, I think most of you probably remember what the main jobs of the limbic system are, right? Okay, primarily the limbic system is involved in emotion, okay, but also in memory as well. So if you have damage to the limbic system, you're looking at potential impairment of short-term memory as well as some changes in your emotional state, maybe mood swings and that kind of thing. Another important structure that's located deeper inside the cerebrum is the basal ganglia. And again, this picture is for you to just be able to visualize how the basal ganglia is deeper inside your cerebrum, not for you to try and remember what all the different parts of the basal ganglia are called. But the job of the basal ganglia is to help regulate movement, especially the movement that's controlled by your skeletal muscles. Now, the basal ganglia is not involved in movement the same way your motor cortex is. Okay, so it doesn't actually cause your arms and your legs and your fingers and other parts of your body to move. What the basal ganglia does is to add gracefulness to your movement. It helps control your posture, it helps control your muscle tone, it helps to coordinate your muscle movements so that you are more graceful and you're not so clumsy. Okay, now the basal ganglia may add some movements to help you be more graceful and to help you keep your balance. For example, when you walk, you know, you're not just moving your legs, right? Usually when you walk, you also swing your arms. Okay, and the reason for you to swing your arms is to help you maintain your balance more easily so that you can walk more gracefully. Okay, those kinds of arm movements are added by the basal ganglia. We call them automatic associated movements, and their purpose, again, is to help you with your balance and to be more graceful. Now, if your basal ganglia gets damaged, you aren't going to see somebody who's paralyzed, who can't move. What you're going to see is somebody who has what we call a movement disorder. So they can still move, but they're going to have some problems. For example, have you ever seen somebody with Parkinson's disease? It's fairly common, so I think a lot of you have probably seen somebody with Parkinson's. What happens in Parkinson's is you don't see somebody who is paralyzed, who can't move, but you see somebody who has movement problems. Their balance is poor. They may have problems with tremors. When they walk, they take these little tiny shuffling steps. So here you can see what happens to the posture of somebody who has more advanced Parkinson's disease. And of course, you know, if you have problems with your posture like that, that is going to throw off your balance. You'll also see problems with things like tremor, having trouble initiating movement, rigidity of joints, and that kind of thing. Now, you're going to study a lot more about Parkinson's disease when you get into MedSurg 1. So as long as you remember that Parkinson's is a problem with the basal ganglia, and if you remember what the basal ganglia does, that'll make it easier to understand all the problems that occur. Okay, the second region of the brain that I want to talk about is the diencephalon, and you see the red arrows pointing at where the diencephalon is located in your brain. It's sort of like connecting the cerebrum with your brainstem. Now, there are two main parts to the diencephalon. There's the thalamus and the hypothalamus. Let's just say a few words about each of those parts of the diencephalon. So here you can see where the thalamus is located, and basically the thalamus has two different jobs. The first job is related to its position in between the cerebrum and the brainstem. Because one of the things that the thalamus does is it takes the nerve impulses that are coming up from the spinal cord through to the brainstem, and it directs those nerve impulses to the appropriate place in the brain. Okay, so that's why this slide calls the thalamus the gateway to the cerebral cortex, because all of the impulses that are coming up the spinal cord and the brainstem have to kind of pass through the thalamus, and the thalamus makes sure that those nerve impulses get directed to the appropriate part of the brain. The other function of the thalamus is that it contains part of the reticular activating system, or we call it RAS for short. You remember what the job of the RAS is. Okay, it's kind of involved with keeping you awake and alert. Okay, so if your reticular activating system's not working, you're probably going to see some changes in level of consciousness. But here's an interesting thing for you as students, and that is if the reticular activating system is not working, then none of the higher brain functions can occur. Okay, now, higher brain functions, what's higher than your thalamus? Well, your cerebrum, right? And you remember your cerebrum is where your learning and your thought processes occur. So if your reticular activating system is not working, then the higher cognitive functions like learning and thinking can't occur. Because after all, it's hard to think if you're not awake, right? Okay, so for that reason, I don't want to hear that any of you are studying for the exam by putting a recording of my voice under your pillow and listening to it while you sleep. Because remember, if your reticular activating system is not working, none of the higher brain functions work, and so you aren't going to remember any of the stuff that you listen to while you're sleeping. All right. Let's talk about the second part of the diencephalon, the hypothalamus. Now, we did talk about the hypothalamus a few class periods ago. Remember, we said that one of the things that the hypothalamus does is that it produces releasing and inhibiting hormones that then tell the anterior pituitary how much tropic hormone to produce. And in that way, it can affect the amount of hormone that is produced by your thyroid and your adrenal cortex and your reproductive organs. Okay, so that's one job of the hypothalamus, to help regulate hormone secretions. Okay, but there are a couple other things that your hypothalamus does as well. The hypothalamus does help regulate your autonomic nervous system. Remember, we've been talking about the autonomic nervous system pretty much all quarter. It's divided into the sympathetic versus the parasympathetic systems, right? And the hypothalamus helps to regulate the activity of the autonomic nervous system. And we're going to talk a little bit more about that in class. The last thing that I want to mention that the hypothalamus is involved in is it does help regulate a lot of your basic body functions. Things like sleep, appetite, thirst, body temperature, all of those things regulated through the hypothalamus. So you can see the hypothalamus is actually a really, really important part of your nervous system. All right, let's talk about the cerebellum next. The cerebellum is like that ball-shaped thing that's at the very base of your brain. And in some ways, the cerebellum is a lot like your basal ganglia in that it doesn't initiate body movement, but it does help to coordinate and smooth out body movements so that you're more graceful and that your posture and your balance is better. Okay, the cerebellum is involved in improving the, quote, accuracy of your movement. In other words, it helps you control the speed of your movement, the timing and the trajectory and the acceleration of your body movements. A lot of the tests that you learned how to do in health assessment with the neuro exam, some of those tests were designed to assess cerebellar function. For example, do you remember that test where you ask the patient to touch their nose and then to touch your finger and then to touch their nose again, and you keep moving your finger around to see if the person can keep touching your finger? Okay, that's a test to assess the accuracy of movement. You know, if the patient can't keep touching your finger or overshoots its target or whatever, that indicates that there's cerebellar disease. Also, remember the Romberg test? Okay, this is the one where you have your patient stand with their feet together and close their eyes, and you see if they lose their balance. Okay, now if the patient cannot maintain their balance unless they widen their stance, they take a step out and widen their stance, that indicates that there is a cerebellar problem. Okay, so a lot of the things that your cerebellum does is necessary for you to do sports, to play musical instruments. You know, if you're going to play the piano, your fingers have to be very accurate. The timing and the speed and everything has to be very precise. So you see in this slide, they're saying, okay, look at this gymnast. Okay, how is she using her cerebellum? Okay, remember, cerebellar function includes regulating posture, regulating balance, controlling the speed and the accuracy of the movements, all of those things that she needs to do in order to not fall off that balance beam and hurt herself. A lot of that is controlled in the cerebellum. So, when you watch gymnasts or other athletes or musicians, you know that those people have really good cerebellums. Okay, the last part of the brain that I want to talk about is the brainstem. And you remember we divide the brainstem up into 3 parts, right? The midbrain, the pons, and the medulla. Now, your brainstem does a whole bunch of things. For example, the midbrain also contains part of the reticular activating system, along with the thalamus. And the brainstem also helps regulate the autonomic nervous system, along with the hypothalamus. So right there, already, 2 very important things that the brainstem is involved with. But remember, the brainstem also contains some really important respiratory centers. There in your pons and medulla, we have respiratory centers that help regulate breathing. And remember, we said that if you damage the respiratory centers in your brainstem, then you're going to see people with very irregular, very abnormal breathing patterns. Also remember that there are some very important cardiovascular control centers that are located in the medulla part of your brainstem. Remember the cardioinhibitory and the vasomotor center that is involved in regulating your heart rate and your blood pressure. And besides those respiratory and cardiovascular centers, there's also a vomiting center, a swallowing center, a cough center. So again, some very, very important control centers located there in your brainstem. Okay, one last thing I want to mention. The medulla, if you remember, is the place where a lot of the major sensory and motor fibers cross over from one side of your body to the other. Okay, so that each cerebral hemisphere controls the opposite or the contralateral side of the body. So you see where the red arrow is pointing, that's where the sensory and motor fibers are crossing over to the other side of the body. We call it the decussation, okay? And here you can see that because of that crossing, that if you damage the right side of your brain, that affects the sensory and motor function of the left side of your body and vice versa. So we call that, the brain, each hemisphere of the brain controlling the contralateral side of the body. We're going to look at that in more detail when we talk about stroke. Now, obviously, because the brain is so critical to the function of the rest of the body does have several mechanisms to protect your brain. In this slide, we see the most obvious protection, which is your skull. Right? Your skull is made out of bone, it's hard, so if somebody hits you on the head, that skull can help protect your soft, squishy brain from being damaged. Another thing that you have to protect your brain is the blood-brain barrier, and we've already talked about how the blood-brain barrier protects your brain. So I really only want to talk about the other 2 mechanisms that protect your brain. Besides your skull, besides your blood-brain barrier, you have your meninges and your cerebral spinal fluid that is protecting your brain tissue. Let's talk about the meninges first. You remember that your meninges are like connective tissue coverings that surround the outside of the brain and the spinal cord. And it's there to help protect your brain and the spinal cord. Now, you remember that there are 3 layers of meninges, right? You have your pia mater, that is the layer that surrounds the surface of the brain and the spinal cord. And this layer not only helps protect your brain tissue, but it also contains a lot of blood vessels that supply blood to the brain and the spinal cord. The middle layer of meninges we call the arachnoid mater, and this is the layer that has a space in the middle of this layer that we call the subarachnoid space. And it's in this subarachnoid space that your cerebral spinal fluid circulates. And the cerebral spinal fluid also has some protective functions, which we'll talk about in a minute. But in this slide, can you see where the spaces are in the arachnoid mater? And that's where the cerebral spinal fluid circulates. Now, the very outside layer of meninges we call the dura mater, and the dura mater is a lot tougher, and it provides the brain and the spinal cord with the majority of the protection that it receives from the meninges. Now, inside the skull, the dura mater forms two major folds, and the purpose of these folds is to sort of support and protect the brain. The first fold is a longitudinal fold, or it goes up and down, and you see the number 1 is pointing towards that fold. We call it the falx cerebri, and what it does is it divides the cerebrum into the two hemispheres, the right and the left hemisphere. Okay, the second major fold is a transverse fold, or it goes side to side. Okay, and we call it the tentorium cerebelli. And the number 2 in that picture is sort of pointing at the tentorium. And the purpose of the tentorium cerebelli is to divide the cranial compartment into two sections. We've got the supratentorial compartment and the infratentorial compartment. Remember, supra means above, infra means below, so the supratentorial compartment is above the tentorium, and the infratentorial compartment is below the tentorium. Of course, there is a hole in this fold, a hole that is in the middle that we call the incisura, or the tentorial notch. And the purpose of that hole is to allow the brainstem to go down through it, okay? But the main thing that I want you to remember about the tentorium is it divides the cranial cavity into those two compartments. And when we get to class, I'll tell you why you care that there are those two compartments, okay? But for right now, all I want you to do is to notice that the tentorium divides the cranial cavity into the supra versus the infratentorial compartments. Okay, the fourth thing that protects your brain is cerebral spinal fluid, or we call it CSF. And you can see in this slide where the CSF is produced. It's produced in the ventricles of your brain. And you can see the little black arrows pointing towards where those ventricles are. Now, the cerebral spinal fluid that's produced by the ventricles of the brain then circulates around the brain and the spinal cord in the subarachnoid space. This slide may give you a little bit better picture of where in the brain the CSF is produced and how it then goes on to circulate around the brain and the spinal cord to protect it. Now, the CSF does have two kinds of functions. The first one is, of course, protective, because as the fluid circulates around the brain, it can provide some cushioning and also help diffuse the impact of any blows to the head that the patient may sustain. So if somebody comes and bops you on the head, the fluid can kind of cushion and hopefully prevent the brain cells from getting squashed and damaged. Okay, the CSF also helps protect the brain by providing a fairly stable chemical environment for the brain so that there aren't major changes that are going to disrupt the function of the brain cells. Okay, the other big function of CSF is nutritive. It does serve as a medium for nutrients and electrolytes to diffuse into the brain cells, and then of course it provides a place for waste products to diffuse out of the brain cell. So CSF serving some very important functions. Now, if anything goes wrong with any of those protective mechanisms we just talked about, then of course the likelihood of the brain becoming injured goes up. So, I've listed for you on your study guide some things that commonly cause damage to the brain. There could be trauma, tumors, infection,
But what I want to talk about now is not the trauma or the tumors or the infection, but I want to talk about what it is that goes on inside the brain when those kinds of things happen. What is the pathology that occurs inside the brain if there's a tumor or if there's infection? What is it that causes the brain to malfunction? Okay, so there are at least 3 problems that we as nurses are concerned about. Those 3 things are hypoxia, increased intracranial pressure, and brain herniation. So let's say a few words about each of those things, starting with hypoxia. So I'm sure you remember this slide back from our first recorded lecture, and I'm also sure that you're really familiar with the concept of hypoxia by now. But just to review quickly, if your brain cells aren't getting enough oxygen, then they aren't going to be able to make ATP, and so they're not going to be able to function normally, and might even become injured or die. Now, hypoxia in the brain can either be focal, meaning it affects only a small area of the brain, as might happen if somebody had a stroke, or it can be global, meaning it affects the entire brain, as you might see if the patient went into cardiac arrest. So you can see there are lots of things that can cause hypoxia in the brain. The second way the brain can become injured is if the intracranial pressure increases. Okay, so the intracranial pressure just refers to the pressure inside the skull. Okay, so you remember your skull is made out of bone, right? So it can't stretch. So if you increase the amount of stuff that's inside the skull, then the pressure inside that skull is going to increase and cause problems. Okay, so let's think about what's inside the skull. There are basically 3 things inside your skull. There's brain tissue, there's blood, and there's cerebral spinal fluid. If you have an increase in any one of those 3 things that's inside the skull, then the intracranial pressure might go up. If there's a small increase in one of those 3 things that's inside the skull, it's possible that we could compensate for that by having a small decrease in one or both of the other 2 things that are inside the skull. And if we were to do that, we might still be able to keep this person's intracranial pressure within normal limits. Now, that idea that we could compensate for small increases in one of those 3 components by having a small decrease in one of the other 2 components, that idea is so important that there's a special name for it. We call it the Monroe-Kelly doctrine or the Monroe-Kelly hypothesis. Now you see it illustrated in this particular slide. The graph on the top shows the 3 things that you find inside your skull: brain tissue, CSF, and blood, right? And in the graph below it, you see that there's been an increase in the amount of brain tissue inside the skull. Maybe this person's growing a brain tumor, right? And so now they have a lot more brain tissue inside their skull. So do you see what happened there? The increase in brain tissue was compensated for by having a decrease in the amount of CSF and a decrease in the amount of blood that's present. And by doing that, the intracranial pressure, or the pressure inside the skull, is able to stay constant. Does that make sense? The Monroe-Kelly hypothesis only is true, though, up to a certain point, okay? Because there's only so much compensation that can take place. Probably the thing that you can shift the most of is your cerebral spinal fluid, because you remember your cerebral spinal fluid circulates in the subarachnoid space around the brain and the spinal cord. So if there's an increase in, say, brain tissue inside the skull, we can shift some of the cerebral spinal fluid. Instead of having it circulate around the brain, we can make more of it circulate around the spinal cord, which means it's out of the skull, and we can hopefully keep intracranial pressure normal by doing that. But the other 2 things that are in the skull, you can't really shift that much of. Like brain tissue is pretty stationary, right? So it's not like you're really going to be able to shift brain tissue out of your skull. Blood you can shift, but if you shift too much of your blood out of your skull away from your brain, then your brain's going to get a little ischemic, right? So in terms of the Monro-Kelly hypothesis, there is some small compensation that can take place, but only up to a certain point. Does that make sense? Now, if things progress beyond what the Monro-Kelly hypothesis can compensate for, what do you think the consequences of that are going to be? Well, two things will probably happen. The first one is that the brain's going to become ischemic, right? Remember we said you could only shift so much blood away from your brain before your brain becomes ischemic. But the other thing to keep in mind is when the intracranial pressure becomes higher than your mean arterial pressure, your heart is no longer going to be able to pump blood up into your brain, right? Because there's just so much force that your heart can generate. And if the pressure inside the skull is too big, the heart is not going to be able to force blood up there anymore. And so the brain is going to become ischemic. Okay? The other thing that we said could happen if the intracranial pressure gets too high is we might see some brain herniation occurring. And brain herniation happens to be the third thing that we said we as nurses are worried about. So let's talk about brain herniation. Brain herniation is what we call it when the intracranial pressure in one of the brain compartments gets great enough that it starts shoving the brain tissue over to other places inside the skull where it doesn't really belong. And the problem with that is as we start shoving brain tissue, it might get pressed up against the skull, or it might get pressed up against the falx cerebri or the tentorium cerebelli, and it gets squished. Okay, I don't know if you actually dissected brains in A&P lab or anything like that, but your brain tissue is actually kind of soft and squishy. And so if you start squishing it against the skull, it can become damaged, or for sure it's going to become ischemic, right? Because when you put pressure on it like that, it's going to compress the blood vessels in that tissue. And so now we're looking at brain damage. Okay, now in this picture, you can actually see the two compartments, right? We talked about the supratentorial compartment and the infratentorial compartment. And you can see that if the increase in intracranial pressure is coming from the supratentorial compartment, it could either shove brain tissue from one hemisphere to the other hemisphere, or it could shove brain tissue from the supratentorial compartment down to the infratentorial compartment. And, if the increase in intracranial pressure was coming from the infratentorial compartment, that could either shove brain tissue back up into the supratentorial compartment, or it could maybe shove brain tissue down through the foramen magnum. Okay, so this is actually why I said that you want to notice the supra and infratentorial compartments, because when we start talking about brain herniation, this is how you're going to know where the increase in pressure is and where the brain tissue is getting shoved to, by thinking about the supra versus the infratentorial compartment. Now, we were saying that if there is downward pressure being exerted, we might start seeing brain tissue getting pushed down through the foramen magnum. So do you remember what your foramen magnum is? It's that hole at the bottom of the skull that allows the spinal cord to exit out of the skull and continue down the vertebral canal. Now, regardless of whether the increase in intracranial pressure is coming from the supra or the infratentorial compartment, as long as there's downward force being applied, we could see brain tissue being shoved through that foramen magnum. And that's especially worrisome if it's the brainstem that's being shoved through the foramen magnum, because the brainstem is wider than the foramen magnum. So if you start shoving it through, it's going to get damaged. And you remember all of those very vital control centers that are in the brainstem, right? We have our respiratory centers, we have our vasomotor and cardioinhibitory center, All of those things are controlling your breathing, your heart rate, your blood pressure. If that brainstem gets damaged, now we're looking at somebody who's going to be hemodynamically unstable, and, their life is now at risk. So can you see now how each of these three things can end up causing brain damage, right? Now, the consequences of that damage are going to depend on which parts of the brain are affected and what the function of that part of the brain is. That's the reason why we took the time to talk about what happens in each part of the brain. But in general, if there's damage to what we call the higher brain centers, like your cerebrum or your cerebral cortex, we would expect to see changes in level of consciousness, changes in cognitive ability, changes in sensory and motor function. But if the damage is to the brainstem, remember all those really vital control centers that are in the brainstem. If there's major damage to the brainstem, we're probably looking at somebody who's going to die. All right, let's look at some specific disorders of the brain now, starting with cerebral vascular disease, because this is probably one of the most common brain problems you're going to run into today. Cerebral vascular disease is a disorder in which blood flow to the brain is interrupted. So the first thing that we probably should do is look at how blood is supplied to the brain. Blood is supplied to the brain in the front by the internal carotid arteries and its branches, and in the back by the vertebral arteries and its branches. And you can see I put little asterisks next to those two arteries. Now, the distal branches of the internal carotid and the vertebral arteries anastomose or connect up at the base of the brain where they form the circle of Willis. Okay, so what we're looking at here is the base or the bottom of the brain. So like if you were lying on the floor and you cut my head off and you were just looking up at the bottom of my brain, okay, that's what you would see. And what they've done here in this picture is they've pulled out those major arteries and separated them so that you can see that they do connect up and actually form a circle. And the purpose of the circle of Willis is to try and ensure that the brain is still going to get blood even if one of those main vessels gets occluded. So if one of them gets occluded, there are alternate paths that the blood can follow to get to all of those parts of the brain. Okay, now, the circle of Willis is not always effective, right? Because if it were, there wouldn't be anybody who had a stroke. But if there was not the circle of Willis, I would bet that there would be a lot more people with strokes out there. So if blood flow to the brain is interrupted, then we have ischemia, and with that ischemia, there's not just a problem with getting oxygen to that part of the brain, but there's also a problem with getting glucose there and with being able to remove the waste from that area. So you put all those problems together, yes, you're going to have impaired brain function. We expect to see maybe some sensory or some motor deficits, possibly some cognitive and language deficits, and if the brainstem is involved, maybe some cardiovascular and respiratory instability. All right, so here are the terms that we use to refer to cerebral vascular disease. We say somebody's had a stroke, a cerebral vascular accident, or a CVA. There are actually two primary kinds of stroke. We have ischemic stroke and hemorrhagic stroke. Let's talk about the ischemic strokes first. Now, the concept behind an ischemic stroke is very similar to the concept behind a heart attack, which is why a lot of people refer to ischemic strokes as brain attacks, not only to point out the similarity between a heart attack and an ischemic stroke, but also to imply that just like a heart attack is a medical emergency, ischemic strokes should be considered medical emergencies as well. So you remember what happens in a heart attack, right? We have atherosclerosis in the coronary arteries, and a clot forms there, which totally occludes blood flow to the heart muscle cells, and so some heart muscle cells die. Okay, that's what's happening in an ischemic stroke, only this time it's the arteries that are carrying blood to the brain that have atherosclerosis. And a clot forms there and occludes blood flow to brain cells, and so now it's brain cells that are dying. So the risk factors for ischemic strokes are very similar to the risk factors for a heart attack because the underlying cause in both of those conditions is atherosclerosis. So if you were to take the list of risk factors for a heart attack, you could use that same list as risk factors for an ischemic stroke with the addition of certain kinds of heart disease that can predispose to ischemic strokes. For example, let's say somebody had infective endocarditis. Okay, we said if a piece breaks off of a vegetative lesion in someone with infective endocarditis, and if that piece travels to the brain and gets stuck in an artery there, it could cause an ischemic stroke. Another example of a heart condition that can lead to an ischemic stroke would be atrial fibrillation. Okay, you remember that we said in atrial fibrillation, the walls of the atria, instead of having nice, strong, unified contractions, the walls of the atria are just sort of quivering, right? So the atria really don't empty well into the ventricles. Blood just sort of pools in the atria, and whenever you have blood that's pooling, what does it want to do? It wants to clot. If clots form in the atria, they can eventually drain into the ventricles and they get pumped to other places in the body. And one of the places those clots frequently end up is in an artery in the brain where they can cause an ischemic stroke. Remember we said that atrial fib is such a common cause of ischemic strokes that if somebody comes into the emergency department with symptoms of a stroke, one of the first things we do is we hook them up to an EKG to see if they're in atrial fib, since that is such a common cause. Now, if a heart problem like that is the underlying cause of the stroke, we have a special name for that. We call it a cardiogenic embolic stroke or a cardioembolic stroke. Again, that just indicates that the original cause of the stroke had to do with the heart. And here you can see the consequences of an ischemic stroke, right? There's a clot in that artery. Blood flow doesn't go past that obstruction, and so all the parts of the brain that are supplied by that particular vessel are going to die. Now, the other way that an ischemic stroke is similar to a heart attack is just like there's often a warning sign of angina before somebody goes on to have a full heart attack, there is often a warning sign before somebody goes on to have a full ischemic stroke. That warning sign is called a TIA, or transient ischemic attack. Sometimes we refer to them as mini strokes. Okay, now what does the word transient mean? It means temporary, right? So a transient ischemic attack is an episode of temporary ischemia, right? So what usually happens is a clot will form and occlude an artery that's taking blood to the brain. And so symptoms that are very similar to a stroke are going to occur. But those symptoms are going to last less than 24 hours. Because what happens in a TIA is that clot that's occluding circulation actually breaks down and blood flow through that artery is reestablished before any brain cells actually die. And once blood flow through that vessel is reestablished, the symptoms go away. Okay, so the official definition of a TIA is that the symptoms will last less than 24 hours. But in reality, those symptoms usually last less than 1 or 2 hours and may actually only last like 15 or 20 minutes. Now, if a patient has a TIA, they should not just say, I guess the next time I go see my doctor, I'll mention it to him or her. Because they need to go get checked right away so we can put in place interventions to try and prevent them from then going on to have a full-blown stroke, because that does happen frequently. According to the Mayo Clinic, in 2022, about 1 out of every 3 people who had a TIA went on to have a stroke, and about half of those strokes actually occurred within a year of the TIA. But they also say that the risk for having a stroke after a TIA is especially high in the next 48 hours, right? And they said 20% of the people who are going to go on to have a stroke, it happens within 7 days of the TIA. So do you see what I mean when I say they should not just wait till the next time they see their doctor, because who knows when that's going to be, right? They need to go in right away and get checked. So the other kind of stroke besides an ischemic stroke is a hemorrhagic stroke. And in a hemorrhagic stroke, the interruption in blood flow to the brain is usually the result of a rupture of a blood vessel. So as you see in this picture, we have bleeding into the brain tissue, which is going to increase the intracranial pressure. And, when the intracranial pressure goes up, the whole brain then becomes compressed and ischemic. Now, the hemorrhagic strokes are not as common as an ischemic stroke, but it does have a higher fatality rate. Risk factors for hemorrhagic strokes include things like aneurysms, right? You know what an aneurysm is? It's like a weak place in a blood vessel wall, so that weak place, it kind of bulges out, right? And here you can see a couple of different kinds of aneurysms. But, if you've got a weak place in a blood vessel in your brain, it is more likely to rupture and cause a hemorrhage, especially if you have hypertension, right? So hypertension is another risk factor for hemorrhagic strokes, because if you have aneurysms in your brain, they're much more likely to rupture if your blood pressure is too high. Also on that list of risk factors, blood dyscrasias. Okay, dyscrasia is just a fancy word for disease. So anybody who has a blood disorder that makes them more likely to bleed is at higher risk for a hemorrhagic stroke. Head trauma or head injury, that's pretty obvious because, blood vessels can become torn or punctured or whatever in that head trauma. Brain tumors can sometimes predispose to hemorrhage because as the tumor enlarges, sometimes it erodes into a blood vessel and causes it to rupture. Vasculitis, what do you suppose that is? Inflammation of blood vessels. And the thing is, when blood vessels become inflamed, that does weaken the vessel wall and makes it more likely to rupture. The last thing on that list of risk factors are AVMs, or arteriovenous malformations. An AVM is just kind of like a tangled up little mass of blood vessels in which there's an abnormal connection between the arteries and the veins. Now, you know that usually arteries flow into capillaries, which then flow into veins, right? And as the blood comes in from the arteries at high pressure, that pressure kind of dissipates in the capillaries and then continues on through to the veins at a much lower pressure. What you have in an AVM is a direct connection between an artery and the vein without going through the capillaries first. Okay? Now, AVMs are usually defects that occur during fetal or embryonic life when the brain vasculature was developing. And so now we have this little defective place where the artery directly connects to the vein. And AVMs actually tend to have fairly thin walls, right? So if you get the blood coming into an artery at very high pressure and it hits the AVM that has thin walls, now we've got high pressure with thin walls, we're a lot more likely to see a rupture and a bleed. Does that make sense? Now, a lot of people have no clue that they have an AVM until it suddenly ruptures one day. There might be some people who have maybe some mild neurological deficits because you remember the AVM doesn't have capillaries, right? And the capillaries are where the transfer of oxygen and nutrients and wastes takes place. So sometimes there might be some mild symptoms, but it seems like the majority of people with AVMs actually don't even know they have them. Now, sometimes somebody might have a brain scan for some other reason, and they might discover an AVM, and that's kind of a lucky thing, because then we can take steps to try and prevent that AVM from rupturing, and so we can avoid that hemorrhagic stroke. But that doesn't really actually happen that often. Now, assessment findings for strokes are not dependent on whether it was an ischemic stroke or a hemorrhagic stroke. The symptoms that you see are more affected by what part of the brain was damaged and what does that part of the brain do. Okay, so I'm fairly sure that almost all of you have seen someone who's had a stroke, right? Because it's actually so common. So if you think about what you observed when you interacted with that person who had a stroke, what kinds of problems did you see? Well, one of the more common things that people notice is they have paralysis or weakness of the side of the body on the opposite side of where the stroke was. You remember we said that the sensory and motor fibers cross over in the brainstem, and so the right hemisphere controls the left side of the body and the left hemisphere controls the right side of the body. So if somebody had a stroke in the right hemisphere, that's going to cause paralysis or weakness on the left side, and vice versa. Okay, so we say that a stroke causes symptoms on the contralateral side of the body from where this stroke occurred. Now, depending on how big an area of the brain was affected or how severe the stroke was, people might have either paralysis or weakness on that one side of the body. Paralysis would be hemiplegia, weakness would be hemiparesis, hemi meaning half, right? And we're talking right half versus left half here. Okay, plegia referring to paralysis, paresis referring to weakness. And you might actually see combinations of these. You know, some people might have paralysis in their right arm and weakness in their right leg, or that might be reversed. It just depends on which part of the brain was damaged and what part of the body that place in the brain controls. People might also have a facial droop of half their face, right? So if you look at their forehead, they won't have wrinkles on that side because, you know, your forehead wrinkles come when you raise your eyebrow, right? And if you can't raise your eyebrow on that side, you're not going to have wrinkles on that side. The eyebrow might droop a little there. The corner of the mouth might droop on that side. It's not so obvious in this picture, but if you ask your patient to smile, it becomes a lot more obvious. People who have strokes might also have problems coordinating different muscle groups. We call that ataxia. And if you think about it, a lot of the everyday activities we do actually require you to coordinate several muscles in order to accomplish, like swallowing. Right? When you swallow, you actually use several different muscles that you have to coordinate. We call difficulty swallowing dysphagia. And people with dysphagia have a high aspiration risk. So we have to really watch them when they're swallowing. Strokes can also cause sensory losses, also on the contralateral side of the body. They might have some incontinence. There might be some cognitive deficits, usually not in the sense that people get confused, but more like they think a lot slower than they used to. They might have trouble making decisions, that kind of thing. And then, of course, they could have some aphasia, especially if the stroke is in the left hemisphere, because the left hemisphere is usually the one that's dominant for language. There might also be some visual deficits. Those can manifest themselves as things like color blindness, maybe some visual hallucinations, or a problem that we call hemianopia. Okay, so you remember hemi means half, right? So what happens in hemianopia is there is defective vision in half of a visual field. Okay, so let me show you some examples of what might happen. So let's say this is what a person with normal vision would see. Someone with hemianopia might lose the left visual field or the right visual field in both of their eyes. Or they may lose the outer visual fields in both eyes, or maybe the inner visual field in both eyes. Okay, it would just depend on where in the brain damage occurred. We might also see somebody with impaired level of consciousness if the reticular activating system was involved. And we might see somebody with what we call hemi-inattention or hemi-neglect. This is a really interesting problem that can occur. What happens in people with hemi-inattention is they don't seem to be aware of the paralyzed side of their body or the environment on that side of their body. And it's not that their eyes or their ears don't work anymore. It's that their brain is not really interpreting the input that comes in from that side of the body. So what you see is people who kind of act like that impaired side of their body isn't really there. So you might see women who only put makeup on half their face because it's like they're not aware of the other half of their face. Or they might seem to be unaware of the environment on that impaired side of their body. It's like they only eat food on half their plate because it's like they don't see the other half of their plate. And you can see in these drawings a similar kind of lack of awareness of part of the environment. I actually used to work on a neuro unit, and I would make rounds with the neurologists, and this one neurologist would do this really interesting thing with the patients who had hemi-inattention. You know, when he was outside the patient room, he would take half his lab coat off, right? And then when he go into the room, he'd stand directly in front of the patient, and then he would ask them to describe what he was wearing. And depending on which side of him they saw, they would either include the lab coat or not. And then he would say, "Do you see anything strange about the way I'm dressed?" And they'd be like, "No." So I read this one book called The Man Who Mistook His Wife for a Hat. It was written by Oliver Sacks, who I don't know if you're familiar with the movie Awakenings, but he also wrote the book that movie was based on. But anyway, he liked to write about some of the unusual things that he saw in his practice as a neurologist. And I remember he told this one story about a patient who had hemi-inattention, and this patient would fall out of bed all the time. And the nurses could not figure out why this man kept falling out of bed, because he wasn't confused or anything like that. So why does he keep falling out of bed? Well, anyway, one day he fell out of bed again, and when the nurses went to go help him, he was really mad, right? He was just, furious. And when they finally got him to tell them why he was so mad, come to find out, he thought that somebody was going down to the morgue and had cut a leg off of a corpse and stuck it in his bed. And he didn't want that leg in there, so he would pick it up and he'd throw it out of his bed. And, I guess this happened several times, but when he picked up that leg and threw it out of his bed, what do you think happened? He fell out of bed, because whose leg was that? That was his leg, but somehow he no longer perceived it as part of himself. Now, that's a very extreme example of hemi-inattention, but I bet you won't forget that, right? So we think that hemi-inattention is somehow related to an impairment in spatial orientation. And it is more common in people who've had strokes in the right hemisphere. Because just like the left hemisphere is dominant for language, the right hemisphere tends to be dominant for spatial orientation, body image, spatial perceptual skills, and those kinds of things. Now, what we usually do in patients with hemi-inattention is we kind of have to train them to turn their head so that they'll notice the environment on the impaired side of their body. And that's just something that they have to learn to get used to. Now, if you look at this chart, you'll also see another thing that's sort of different between right hemisphere versus left hemisphere strokes. We find that as a general rule, people with right hemisphere strokes tend to not be as aware of how impaired they are. They see no reason why they should not get out of bed and walk to the bathroom, not realizing that they have weakness or paralysis on one side of their body. So we have a lot more safety concerns with those people. Whereas patients with strokes in the left hemisphere tend to be a lot more cautious. They seem to be more aware of their impairment, and as a matter of fact, they tend to want you to do everything for them. And they're like, oh, could you do that for me because I'm afraid I might fall, or something like that. And so those people we have to try and encourage more to try and become a little bit more independent. Okay, now that's just a generalization, but it does seem to hold true often enough that you should at least assess your patients to see if they fall into one of those categories. And of course, if the stroke is in the brainstem, now we're worried about all those really important control centers there in the medulla. As a matter of fact, if people have massive brainstem strokes, it's almost always fatal. We usually put those people as do not resuscitate, right? Because they are usually not able to keep their heart rate and their blood pressure stable. It goes up, it goes down, it's all over the place. They tend to have very abnormal breathing patterns. And, a lot of times we can't get these people regulated to where they can have stable vital signs. And so they almost always end up dying. As far as interventions for stroke, of course, that's going to depend on whether it's an ischemic stroke or hemorrhagic stroke, right? If it's an ischemic stroke, we always hope that we can diagnose it in time to do thrombolytic therapy. You remember thrombolytic therapy, we use a drug where we can actually break down a clot. Okay, and the goal is if we can break down the clot and reestablish blood flow through that occluded artery, that we can hopefully save any brain cells that have been damaged but haven't died yet. So you can see in this before and after picture, when they used thrombolytic drugs, they were able to dissolve a clot, reestablish blood flow through that one blocked artery. But of course, there is a window of opportunity for thrombolytic therapy because, the longer you wait, the more brain cells are going to die, right? I ran into this statistic that said that 32,000 brain cells die every second that blood flow to the brain is disrupted. So if you do the math, that translates into 2 million brain cells die per minute. Okay, so time is brain, right? Or time lost is brain lost, right? So we are anxious to diagnose and start treatment as soon as we can. But even though we're in kind of a hurry because we want to salvage as many brain cells as we can, we do have to take the time to establish one very important thing. What do you think that thing is? We need to make sure this is actually an ischemic stroke and not a hemorrhagic stroke by doing a CT scan or MRI or something like that. Because if this is a hemorrhagic stroke and you put the patient on thrombolytic drugs, what have you just done? Yeah, you've just made things 1,000 times worse, right? So yes, we do need to be careful that we have an accurate diagnosis. Now, I mentioned a window of opportunity, right? Usually we're only going to do thrombolytic therapy if we can start it within 3 hours of symptom onset, if that was observed. Or if it wasn't observed, then we have to go within 3 hours of the time the patient was last seen normal or last known well. Okay? Now, that is an important thought, okay? Because sometimes people have what we call, quote, wake-up strokes, meaning they were fine when they went to bed the night before, and when they woke up, they had symptoms of a stroke. And you don't really know when that stroke happened. It could have happened right after they went to bed last night, or it could have happened right before they woke up. So we really don't know how long it's been. And so we have to, be on the cautious side. We're going to count the 3 hours from the time they were last seen normal. This is the reason why. So you remember when an ischemic stroke happens, there's a clot that occludes blood flow to part of the brain, and that part of the brain starts to die, right? If too much time goes by after that tissue died, it's going to start to necrose, right? Including the blood vessel in that area. And if you dissolve a clot and reestablish blood flow in a blood vessel that has started to necrose, what's going to happen? It's going to rupture and it's going to bleed, right? So now you're going to have a hemorrhage on top of that ischemic stroke. So to be on the cautious side, we don't start thrombolytic therapy if more than 3 hours has gone by, okay? Now, there are some exceptions to that in which we might extend that window from 3 hours to 4.5 hours, but there are a lot of exclusions to that 4.5 hours, if they're too old, if they have a past history of strokes, if they're taking anticoagulants, if they have diabetes, there's a whole big long list of exclusions. So, for practical purposes, I want you to remember that 3-hour window of time. That's the time during which we can start thrombolytic therapy. If more than that number of hours has gone by, we won't do thrombolytic therapy. Now, if we have a patient who we've already missed the window of opportunity for thrombolytic therapy, and now our goal is just to prevent a second stroke, or maybe we have a patient who had a TIA and we want to prevent them from having a first stroke. Okay, now we're probably going to bring out antiplatelet drugs like aspirin or anticoagulant drugs like Coumadin. Okay, the risk is not as big with antiplatelet or anticoagulant drugs because you remember those drugs cannot break down existing clots. They're really only going to prevent new clots from forming. Now, our choice of whether to use an antiplatelet drug or an anticoagulant drug really depends on why the clot formed. Okay, clots that are formed in arteries because of the presence of atherosclerosis, those clots tend to be heavy on platelets. There is some clotting factor involvement, of course, but those arterial clots tend to be more platelet-based. Whereas clots that develop because of stasis, like, in atrial fib, right, where we said the atrial walls are just quivering and the blood inside the atria is pooling, and so it clots. Okay, those kinds of clots tend to be more clotting factor based and not so much platelet based. So if it's more of a arterial clot, we're going to choose the antiplatelet drug. And if it's more of a venous or a stasis clot, we're going to choose the anticoagulant drug. Because anticoagulants are, actually working through the clotting factors, whereas the antiplatelet drugs are working through the platelets. Does that make sense? And here's just a little chart that tells you what some of the antiplatelet and anticoagulant drugs are. I'm not going to test you on these drug names. This is just more for your reference, when you get into the clinical setting, and if you have to do care maps and drug cards on your patients, this might be something that'll be helpful. And as always, a big part of interventions is going to involve aggressive risk factor reduction. Okay, so we're going to look at all of those lifestyle risk factors that contribute to atherosclerosis and those kinds of things, and we're going to try and help people modify their lifestyle. So as nurses, we do a lot of the education that is going to help patients with this risk factor reduction. Now, if it's a hemorrhagic stroke, treatment is going to focus more on trying to stop the bleeding and control the intracranial pressure. So, we might do something like surgically implant a clip to, cut off the blood flow through an aneurysm and prevent any more blood loss through that. Or we might insert metal coils in an aneurysm that will then cause that aneurysm to have a big clot in it so that, it's not going to rupture because no blood is flowing through it anymore. So in this picture, you actually see in this AVM, in one place they used coils, but they also show that you can use glue to kind of glue the walls of that vessel together, and now blood can't flow through it anymore, so it won't be able to rupture. So those are some options we have to either stop or prevent vessels from bleeding. And this is an example of something that we might do if the intracranial pressure is getting too high. This is a VP shunt, which stands for ventriculoperitoneal shunt. So one end of that shunt is in a ventricle of the brain, and the other end is in the peritoneal space. And we can actually do that because you remember the peritoneal space is sterile, so it's not like we're going to be introducing organisms into the brain, right? But what's going to happen is if the intracranial pressure starts to increase, that shunt will help drain some of the cerebrospinal fluid out of the skull into some place of the body where, it can be absorbed. And that's one way to keep the intracranial pressure from getting too high. All right, the other brain disorder we're going to talk about today is seizure disorder. Now, your book defines a seizure as an episode of abnormal, uncontrolled neuron activity that starts in the cortex and temporarily changes brain function. Okay, so we have abnormal, uncontrolled activity in the brain cells, and you can kind of see that reflected in this EEG, right? Do you remember what an EEG is? An EEG is an electroencephalogram. And what are we looking at when we look at an EEG? We're looking at a recording of the brainwave activity, right? And you can see during a seizure how that brain activity is just out of control, right? So what kinds of things cause this uncontrolled activity in the neurons? There seems to be at least 3 different kinds of things. First of all, it could be a change in the permeability of the neuron cell membrane. Remember when we talked about generating action potentials, we said when the sodium enters the cell, that depolarizes it and, an action potential occurs. So if you change the permeability of that cell membrane and make it easier for sodium to enter, then we might start seeing action potentials firing out of control with the result of seizure activity. Or it could be that damage occurs to those neurons. And, depending on what the damage is, that can change how easy or difficult it is to generate an action potential. And it's possible that there are certain kinds of cell damage that might make it much easier for sodium to enter and trigger action potentials. And then we would have action potentials firing out of control. Finally, it could have something to do with the amount of neurotransmitter that's present. Remember, we said earlier that The chemical messengers called neurotransmitters do play a role in either facilitating or inhibiting the transmission of the action potential from one nerve cell to the next nerve cell. So if there's an imbalance of those neurotransmitters, that could explain why it might become easier than normal to generate an action potential. And then we would have action potentials firing out of control. Now, we often divide seizures into two groups. We have provoked, secondary, or acute symptomatic seizures, as opposed to unprovoked, primary, or idiopathic seizures. And I put all of those different names for those classes of seizures on there because I think they all give you some clues as to what that type of seizure is all about. So, a provoked seizure is a seizure that's provoked by some other disorder. Okay, so we can usually identify some specific disorder that is triggering or provoking the seizure. Okay, so the seizure is secondary to that other disorder. It's a symptom of that other disorder, and if we can fix or get rid of that other disorder, the seizure should go away. Okay, so examples of a provoked seizure might be the febrile seizures that sometimes occur in babies when their fevers go over 104 degrees or so. Or it could be a seizure that is triggered by a fluid electrolyte or acid-base imbalance, or by hypoglycemia, or by hypoxia. And in those cases, if we fix the electrolyte or acid-base imbalance, we fix the hypoglycemia, then the seizure should go away. So here you can see the febrile seizures, the metabolic-based seizures, even structural things like if there's an infection in the nervous system or there's a brain tumor or something like that. If we can get rid of the infection, we can treat the tumor, then hopefully the seizures go away. Okay, so these are not chronic conditions, right? If a baby has a really high fever and they have a febrile seizure, that doesn't mean that that baby is going to have seizures for the whole rest of their life, right? So these provoked seizures are usually not chronic. They're usually not recurrent. If we get rid of the cause that's provoking the seizures, then the seizures should go away. Unprovoked seizures, on the other hand, don't seem to have an identifiable cause. We can't find a disorder that we can point to that is actually provoking the seizure. The seizure itself seems to be the primary problem, and we don't know what's causing it. It's idiopathic, okay? Those are the seizures that tend to recur and that tend to be a chronic condition. And that's the kind of seizure that we usually refer to as epilepsy. So looking at this picture again, the blue section of that chart is the unprovoked seizure. This is where we have chronic recurrent seizures for unknown reasons. It's usually a genetic or a congenital kind of thing. Now, that uncontrolled activity in the brain cells that occurs during a seizure can cause several different kinds of problems. What you actually see during a seizure is going to depend on where the seizure activity starts and what other parts of the brain it spreads to. But usually you can expect to see these kinds of issues: changes in motor activity, changes in sensory function, and changes in level of consciousness. Now, there's a couple of different kinds of changes in motor activity that you might see during a seizure. The one that most people think of when they think of somebody having a seizure is tonic-clonic activity. And as you can see in this slide, we can divide tonic-clonic activity into two phases: a tonic phase and a clonic phase, right? Okay, so during the tonic phase, the muscles go into extreme contraction, and they stay that way for a period of time. Okay, so usually the arms flex, the legs extend, the body gets really stiff, and they hold it that way. Okay, then the tonic phase is followed by the clonic phase, which is what people picture in their minds when they think of somebody having a seizure, where the arms and the legs kind of alternately flex and extend, and it looks like their arms and legs are just flailing around. We do worry about people being injured during that clonic phase. Of course, they might hit their arms and legs against furniture or against walls. When they fall, they could hurt themselves. They could bang their head on the floor over and over. So yes, we are worried about injury during the clonic phase, but there's also the potential for damage during the tonic phase. Because if you think of what we said happens in the tonic phase, we said the muscles go into extreme contraction and they stay that way for a period of time. Okay? That includes the respiratory muscles. Okay? So if the respiratory muscles contract and they stay that way, okay, what happens? The patient stops breathing, right? So depending on how long that tonic phase lasts, there is the potential for impaired oxygenation. The other kind of change in motor activity that we might see during a seizure is called automatisms. And automatisms are like strange, non-purposeful muscle movements that people tend to repeat over and over, and most of the time they don't seem even aware that they're doing them. For example, people might smack their lips over and over, or they might rub their clothes or fiddle with the buttons on their clothes or wring their hands. Those are the kinds of things that they really don't seem to even notice that they're doing. Automatisms could also include what we call facial grimacing, which is when people make these kind of strange faces, and again, they don't seem to realize they're doing it. As far as changes in sensory function, people might report strange sensations or hallucinations, and those hallucinations could be visual, like they may report seeing flashing lights, or they could be auditory. Sometimes people have ringing in their ears, or they hear sounds that are like rushing wind and nobody else hears that. Or they could even be olfactory. Sometimes they say they smell strange smells that nobody else seems to smell. As far as changes in level of consciousness, you could see anything from somebody who's just kind of mildly confused during their seizure to someone who's totally out of it, and anything in between those two. In some kinds of seizures, usually the kind that involve tonic-clonic activity, there might be what we call a post-ictal phase, where the seizure activity is already over, but the patient still seems really out of it. And they might stay that way for a couple of hours until the reticular activating system starts to function again. During that post-ictal phase, some people are a little bit more aware than other people. Some people will respond to pain, others won't. And healthcare professionals have all kinds of weird ways to try and see if the patient responds to pain or not. But sometimes people just seem really groggy and lethargic, and sometimes they are so out of it that, they almost seem like they're in a coma. But again, that post-ictal phase will usually end when the reticular activating system starts to function. Now, there are a lot of specific subtypes of seizures, and depending on which neurological association's nomenclature you subscribe to, those seizures might have different names. But I think pretty much everybody agrees that we can divide seizures into two main groups. We have the generalized seizures, and then we have the partial or focal seizures. I think your book is using the focal term. instead of the partial term. But you might still see either of those terms used in the clinical setting. All right, so the difference between a generalized seizure and a partial or focal seizure is the focal seizure starts in one hemisphere, and the generalized seizure starts in both hemispheres at the same time. Okay, now a partial seizure starts in one hemisphere, but could spread to the other hemisphere. And so it could look like a generalized seizure. So you can't always tell just by observing the seizure whether it was generalized or focal. Sometimes we actually have to hook somebody up to an EEG to find that out. So this is what it looks like when we do an EEG. You know, we put the little electrodes on their scalp and then we record their brainwave activity. And sometimes we admit patients to testing centers and, kind of hope to catch the activity of a seizure when it occurs so that we can tell whether it starts in one hemisphere or both hemispheres at the same time. And you may wonder why we care whether it starts in one hemisphere or both at the same time if it looks the same, right? The answer to that question is because when it comes to choosing a medication to control the seizure, we find that the generalized seizures and the focal seizures respond differently to the different medications. So if we know which type of seizure it is, it becomes easier to choose a medication that might be able to control that activity. So you might have heard of some people who have what they call an aura before they have a seizure. And the aura is usually described as maybe smelling a strange smell or seeing flashing lights or maybe just having a weird sensation before they have a seizure. And we used to think that auras were like a warning sign so that people knew when they were about to have a seizure. But we now think that auras are actually focal seizures. Seizures that start in one hemisphere, maybe in the part of the brain that controls smells or that controls vision. And, so the seizure actually begins in that part of the brain, which explains the experience of the aura. And then the seizure activity spreads to the other hemisphere. And then the patient looks more like they're actually having what they think of as a seizure. So, the aura is no longer considered a warning sign of a seizure, but is actually the beginning of seizure activity. Usually it's a focal seizure that will then spread to the other hemisphere and, then start looking more like what people think of as a seizure. Does that make sense? Now, like I said, there are actually several different subtypes of seizures, but I only want to talk about the two that I think are the most well-known and the two that you will probably most often get asked about. Both of those subtypes happen to be generalized seizures. Those two are called petit mal seizures and grand mal seizures. So let's start with petit mal seizures. Petit mal seizures are sometimes also called absence seizures, because petit mal seizures are what we call non-convulsive seizures. In other words, you don't have the tonic-clonic movements. Okay? Now, I kind of like the way your book describes petit mal seizures. Your book calls it a, quote, disturbance in consciousness. Okay? Usually when people describe what petit mal seizures are like, they say that the patient just sort of spaces out for a few minutes, so they kind of just sit there and they don't move. They kind of just stare blankly ahead. They're not really focusing or looking at anything. They don't usually respond to you when you talk to them. Most of the time they don't move, but there might be some automatisms. Okay, now petit mal seizures don't usually last very long, and they are most common in kids. As a matter of fact, in kids, a lot of times petit mal seizures just look like, oh, here's a kid that daydreams a lot, right? They're sitting in class and they're just kind of staring off into space and they look like they're not thinking of anything. And a lot of times, teachers want to kind of go, hello, wake up, pay attention, when actually that child is having a petit mal seizure. So here's a photo that I actually got off of TikTok, where here's somebody who's trying to show you what the blank stare that the petit mal patients have looks like. I do have a YouTube video that I'm going to show you in class, so hopefully that'll give you a better idea. But most of the time, petit mal seizures do occur in kids, and in a lot of kids, they seem to outgrow them. In other kids, the petit mal seizure may evolve into other types of seizures, at which point a lot of times we go, oh, they weren't just daydreaming, they were actually having petit mal seizures, and now, they're having other kinds of seizures as well. Actually, though, there are some adults that still have petit mal seizures, so it's not just limited to kids. Now, grand mal seizures are often called tonic-clonic seizures because they usually have that tonic-clonic pattern. And usually in grand mal seizures, you're going to see a loss of consciousness, and often the patient will also lose bowel and bladder control. Grand mal seizures usually last about 60 to 90 seconds, which doesn't sound very long, but let me tell you, if you're standing there watching somebody have a grand mal seizure, that seems like the longest 60 to 90 seconds of your life, because there really isn't anything that you can do to stop it. Mostly what we're doing for tonic-clonic seizures is we're trying to protect the patient from injury. So if they have tight clothes on, we're going to try and loosen that, unbutton their collars so they don't choke. If there's furniture in the way, we try and move it so they don't bump their arms and legs on it. If they're banging their head on the floor, we try and fold up a sweater and stick it under their head so they don't hurt themselves. And then we're kind of just observing and documenting. How long did it last? What happened first? Did they lose bowel and bladder control? Sometimes they even recommend that you video the seizure with your cell phone, if you run into somebody on the street who's having a seizure. And that way the health professionals can watch it, and maybe that'll help determine what kind of seizure it was so that it'll be easier to choose a treatment. Now, people are always like, well, doesn't that violate HIPAA? Okay. It doesn't if you're just showing it to the health professionals. If you post it on social media, then yeah, that might violate HIPAA. But, just give the video to the EMTs when they come or whatever, and you should be fine. We don't recommend putting anything in the patient's mouth. In the olden days, they used to tell us to try and stick something in their mouth so they don't swallow their tongue. Well, I actually think it's physiologically impossible to swallow your tongue. I think what they're talking about is how your tongue might fall back and block your airway. But we don't recommend putting anything in the mouth because, first of all, it's really hard to do. When the seizure starts, usually people just kind of clench their teeth, and you're not going to get anything in there. But even if you manage to get something in there, you are either going to, have that item that you stuck in there break, and now you have a foreign body rattling around in their mouth, or they might break teeth. If you put something in their mouth that's too hard for them to bite through, they might break their teeth, and now they have teeth rattling around in their mouth. Definitely don't put your fingers in there because they might bite on your fingers. So I have a friend who has seizure disorder, and I didn't know that until she had a seizure at my house. And after the seizure was over, I had another friend with me, and we looked at each other and we're like, she's not breathing, is she? And, I had a brief moment of panic because in my head I was going, where's my stuff? When I'm at the hospital, I have my oxygen set up, I have a suction set up, I have an ambu bag that I can use to force air into her lungs, and I don't have any of that stuff at home, right? So I'm like, wait, where's my stuff? But then I remembered, that head tilt chin lift thing they teach you in CPR. Well, I did that and it works, okay? But it is worth spending a few minutes to think about what you would do if you ran into somebody having a seizure on the street, right? Because this is one of the more common things that you're going to run into out of the hospital that might require you to take action. Sometimes, when you're on the airplane and you hear the pilot get on the intercom and say, is there a doctor or a nurse on board? And, you kind of always look around and hope somebody else gets up. But, so think about what you would do. Actually, when my daughter was younger and she was on the swim team, there was one afternoon where a swimmer had a seizure in the pool. Okay, I actually ran into a former student who told me that she walked into the bathroom at Target and there was a lady having a seizure in the stall. So you do need to think about what you would do if you ran into somebody having a seizure and you were not in the hospital setting. Now, there is a condition called status epilepticus, which is what we call it when the seizures either don't stop on their own or they occur one after the other without the patient recovering in between. Now, it can happen with any kind of seizure, but we worry about it most with the tonic-clonic types of seizures, because you remember during the tonic phase, the patient stops breathing, right? So if the tonic phase lasts long enough, people can go into respiratory failure, they might even die. Now, usually, if the seizure lasts longer than 5 minutes, then we're going to start treatment, which usually involves giving some kind of IV anti-seizure medication. So if you have a patient with a history of status epilepticus, you always want to make sure they have IV access so you can use it if they have an episode of status. Otherwise, you're going to be trying to start an IV while the patient's seizing, and that can be challenging. Now, if status epilepticus lasts like 20 to 30 minutes, now we're kind of worried that there might be brain damage because, if there's that abnormal, out of control brain activity that lasts that long, the brain cells have pretty much used up all the glucose and now they might become damaged because there's no fuel. Does that make sense? So we need to stop that status epilepticus as soon as we can. As for interventions, if it's a provoked seizure, all we have to do is figure out what disorder is provoking the seizure and we fix that. And if we fix the thing that's provoking the seizure, then the seizure activity should go away, right? But if it's an unprovoked seizure, we don't know what's causing the seizure. And so now we really have to resort to some kind of anti-seizure or anticonvulsant medication. Now, you'll learn a lot more about these seizure medications probably in peds when you learn about seizures in kids. But all I really want you to know about the seizure medications at this point is most of them are going to work either by changing the entry of electrolytes into the cell, because you remember that's what triggers the action potentials that are firing out of control, okay? Or the medication will alter neurotransmitter activity. And you remember neurotransmitters also have a role in the generation or the transmission of the action potential. Then we'll try and help the patient identify their triggers so they can avoid them. Common triggers for seizures are being overtired, being stressed, not taking their medication. So, we might need to periodically check the blood levels of their medications, because if the blood levels of those drugs drop too low, then the patient might have a seizure. Sometimes alcohol or certain kinds of drugs can trigger seizures. And then some people are susceptible to things like flashing lights. As a matter of fact, there are actually some video games and some movies that come with a seizure warning because there are flashing lights or other things that might trigger seizures in susceptible people. There are actually some Broadway shows that come with a seizure warning as well. I actually went to see Wicked one time, and there was a sign with a seizure warning. And I wished I had taken a picture of it, so I went home and I did a Google search, and this is the closest thing that I could come up with. But the other thing that we want to do is we want to teach patients to avoid situations that could be dangerous if they were to have a seizure, like driving. Okay, different states have different laws, but in some states, you can't have your driver's license restored to you until you've been seizure-free for a certain number of months. But there's also just everyday things like they suggest that people take showers instead of tub baths, because if you have a seizure, you are less likely to drown in a shower than in a bathtub. Or, going up on ladders or riding bicycles or riding horses, So you need to think about, how likely is it that this person will have another seizure, and, what should they avoid in order to be safe. And then there's also the psychological aspect of interventions with our seizure patients. Some of these patients whose seizures are not well controlled have a lot of anxiety around, well, when is the next time I'm going to have a seizure, and what will I be doing? And, they sometimes develop anxiety, depression, self-esteem issues, especially in teens, because, they get embarrassed if they have a seizure in front of their friends, and they don't want to feel different. Okay, so a lot of psychological support is needed as well. All right, that's it for today. If you have questions, just send them to me and we can talk about them in class. All right, see you then.